Hi there, and welcome back to the Dutch Podcast. I'm Dr. Jacqueline Smeaton, and on this podcast, we dive into the vast and ever-evolving world of hormones as part of our lifelong pursuit of better health. Here at Dutch, we've dedicated over a decade to transforming lives by addressing hormonal imbalances like cycle irregularities, perimenopause, menopause, and more. Our mission is clear: to simplify and advance hormonal health for everyone. On this podcast, I get to bring you cutting-edge insights from our top experts on hormone therapy, menopause, personalized medicine, and more. We're all aimed at making a real difference in your well-being. Your questions and feedback are crucial. They shape our discussions and help us navigate the complexities of hormone health together. Now, as always, please remember the content of this podcast is for educational and informational purposes only, should not be considered medical advice. Be sure to consult your healthcare provider for medical advice, diagnosis, and treatment. I am so excited about our podcast today. I'm going to be talking with Dr. LaKeischa McMillan all about perimenopause, menopause, HRT, and really how to serve women as they move through their 30s and 40s and beyond. Now, Dr. LaKeischa is an OBGYN, and her mission is really to empower women as they age to feel confident, knowing how to balance their hormones, because she knows this is essential for healthy living. Dr. LaKeischa graduated cum laude from Oakwood College in Huntsville, Alabama, with a Bachelor of Science in Biology and earned her medical degree at Loma Linda University School of Medicine. Now, on top of her clinical practice, Dr. McMillan's also a speaker and a writer on all kinds of women's health topics. She's a contributor to a lot of online and print publications, and really everything she does is about her commitment to providing women with information and resources they need to get relief from their symptoms and make informed decisions about their health. She is compassionate, she's knowledgeable, she's dedicated to women, and she is a boatload of fun. So I'm so excited to dive in with Dr. LaKeischa today. So Dr. LaKeischa, we're so excited to have you here and welcome.
Thank you. I'm so excited to be here.
So I want to start by talking about a topic that when we surveyed our customers, it was literally the most desired area for information and education, and the biggest reason why people order the Dutch test, which was perimenopause. And that was a big surprise to me because, we think about menopause a lot, but of course, perimenopause is this like extended almost decade of life for a lot of women. So I want to start by talking about that, and tell me a little bit about when you tend to see women come in with, complaints around perimenopause, and what are you seeing for women in this phase?
Wow, thank you. Oh my goodness. So this is a topic that I love to talk about. So Dr. Jacqueline, you may have to tell me it's time to stop. You have to give me the cutoff, the 20-second timeout, as some people would say. So just, this is the hill that I love to speak on. And what I see is I see women coming to me in their 40s. Around the mid 40s is when they start actually asking or saying something. They could have been experiencing some symptoms even in their early 40s, but just were like, no, I'm not sure. What is this? They go to a practitioner. They think, for instance, if it's a sleep issue. So a lot of them are coming saying, my sleep is different. I have, of course, I'm gaining weight for seemingly no reason. The other one is, oh, wait, what was I thinking again? I went into this room. I know I came in here for something, or I'm, in the C-suite and I can't string my words together like I used to. Am I starting to have early onset Alzheimer's? So those are just a few of them. And the other, of course, is exhaustion. They're just like, I am exhausted. I just cannot get through what I used to get through on the amount of energy that I have anymore. And then they also are complaining about their intimacy. So when they come to me, these are some of the laundry lists that they come with. And like I said, around that mid 40s, late 40s. And so because of the space that I've been in for almost a decade myself, I'm like, tell me more. Or I'll tell them, you're not alone. I wish I had a tape recorder, and I'm dating myself so I could press rewind and play. And that is when we have this conversation. And I say, we need to see where your hormones are, what your body is doing with them, how you're metabolizing them, and go from there.
I feel like you were a fly on the wall at like mom's night out a lot with me and my friends, because you just hit the nail on the head of that experience for sure. So What is happening hormonally in perimenopause? And I'd love to know how you're talking about this with your patients because it's a complex time to try to explain what's happening.
Absolutely. So I start out by telling them first, let's bust a myth about perimenopause. It is not just an age related diagnosis. Okay. So you don't have to get to a certain age and check off a box and go, yes, I'm now in perimenopause. It is where your hormones are changing at such a rate or in such a dramatic fashion that it is showing up as a symptom for you. Your physiology has changed. Whenever I give lectures or talk to I do moms, weekends. I actually did one here recently. I'm here in the local Maryland area for a group of moms, and I show this graph that I love. I love visuals. I'm very visual. So I showed this graph of what your hormones are doing when you're in that reproductive phase of life, when you start having your cycle more regularly. And we're talking about somebody that's having it at a set interval every 28, 30, or 32 days or something like that. Your estrogen starts going up at a certain time. Your progesterone starts going up at a certain time. Your testosterone even starts going up, and they start dropping. When you get into perimenopause, I love to show them this graph because it just shows where everybody's doing their own thing. People are dropping when they shouldn't be dropping. They're not going as high as they used to. And so how does this show up? It shows up as the symptoms that you come to me with. So it's either going to show up as your cycle has changed. And that's what one of the textbook definitions of perimenopause is that your cycle changes by 7 days. Either it starts coming closer together, which means you start having it like every 3 weeks for some people, or it starts lengthening out. So you start having it further apart. And that's one of the things that is a big one that can show up, and somebody will recognize that and go, oh, yeah, my cycle is different. My cycle has changed. The characteristics of your cycle can change. So some people that had heavy cycles can start having lighter cycles, or those that had lighter cycles can start having heavier cycles, can start having cramping and start having some of those PMS symptoms they did not experience before. So when your body starts changing, I tell them all the time, when your body starts changing, because you're in your body all day, every day, you come to me and I just see a snapshot in time. This is what is happening. This is how it is showing up. It is showing up as true symptomology. And so we need to make it and we need to address it.
First, what an awesome service you do to your patients to acknowledge that they're the expert on their experience and their body. So thank you for that. I love hearing that because I think so many patients come in and feel like their doctors are trying to like supersede what they're experiencing or tell them they're not experiencing it. So how amazing for you to do that. Thank you for on behalf of all of us women out there. Now, I think that what you're describing is like it's so valuable to hear you explain it because that cycle change can be really frightening maybe is
Yes.
the right word to women
Yes.
or surprising. They don't know to expect
Yes.
it. And
Yes.
with our listeners, like we have a lot of really highly educated patients who love hormones and want to learn more. So they're definitely on the phone listening in today in their cars. Hello to all of you. And we also have a lot of providers who are wanting to serve their patients as best they can. And one challenge I hear over and over again from providers is like, at what point do we intervene? Because what you're describing is a normal physiological change in expectation. So one path could be providing support and reassurance for patients. And sometimes for women, those cycle changes, heavier, lighter, spotting, unpredictability, irregularity, shorter, longer, those changes can be disruptive or problematic. So how do you as a provider like listen to your patient and decide? And I'm asking this because I think our listeners would love to hear it from the provider and the patient perspective. When is it quote unquote something wrong that needs to be managed, or when should I just let it ride?
Oh, this is a great question. I love this question because it is where you come into partnership with your patient. And so you have to sit down with them. And I usually say, tell me your story. And somebody will go, you want the whole story? Like, where do I begin?
How much time do we have?
Right. How much time you got? And I'll say, okay, let's start with the change, how things started changing. Tell me from that beginning. Tell me what's going on. And then I'll say, okay, let's pick maybe the big one that's kind of interrupting your life, or the big 3 symptoms that are interrupting your life. Let's start there. And if it is interrupting to the point where it is causing a interruption in relationships, if it is impacting your ability to perform in your job. Classic example will be the woman who all of a sudden she's late to work now. Like, what is the issue? Well, she didn't get good sleep the night before because her progesterone has dropped. And so we don't have that communication with the neurotransmitters to start that nice little cascade in our brains to help us start the sleep cycle. So now she's getting up doing the two-step shuffle. She's walking around. She's like, okay, wait, what do I do now? What? And so now it's interrupting life. It is interrupting her ability to be a contributing member, how she would like to contribute to her society and her community, and how she would like to show up. So if it's interrupting your life, if it is being impactful, then it's time to intervene. And then we can say, how do you want to intervene? And that's when I say, let's go into my hormone hottie handbag and let me see what tools I have that I can give to you so that you can actually be an informed consumer, because informed refusal is just as important as informed consent.
I love that. So tell me a little bit about what's in that hottie handbag. I mean, what are you using with women in perimenopause?
I love it. I use a variety. So I'll say, hey, you have the option of doing lifestyle changes. Let's look and see what's going on. And this is why I love the Dutch test. Okay. So I'm probably like one of the biggest cheerleaders of the Dutch test. I love it, love it, love it.
Thank you.
This is where I say, okay, let's see what your body said about you. Let's see how it told on you. So let's look at those adrenals. I love that the Dutch test plus actually is what I use a lot of with my perimenopausal women. Tells me, hey, this is what's going on with her adrenals over here. Let me tell you about her stress. Let's tell you about how that's impacting how all of this is working, right? And so I'll say, what's going on? How are you able, what in your life do we need to put some supports around? So it's not only lifestyle, but then there may be supplementation. Let's get these adrenals nice and calm and quiet. Or let's make sure that you're metabolizing the hormones that you have on board properly. Or maybe you need some bioidentical hormones. And that's what I choose to use to be able to help support your physiology so that you can show up the way that you've been showing up before. And so it's lifestyle, it's supplementation, it's hormones, it's bioidentical hormone therapy, as well as, hey, let me help you put together your healthcare team. Let's see who needs to be in your Rolodex. Do you need a life coach? Do you need a therapist? Do you need an acupuncturist? Do you need a chiropractor? Who else needs to be on your team of experts?
I love that. And this is such a transformative time for women because perimenopause oftentimes coincides with like kids leaving the nest or kids getting to an age where they're more self-sufficient. And like for, as a mom myself, we've got 7 kids at home. So it's like busy mom life. It's really, you give a lot of yourself to support your family, but then you start to see that load lift and you actually have the bandwidth to like say, oh, wait, maybe I should be taking care of myself now. That I love that you're thinking about building that team. And I love the things you're mentioning that are so much more comprehensive than just let's fix your hormones, because it is about so much more than that as you like reimagine life after family, if you've had a family.
Absolutely. Absolutely. I say that all the time. I'll say, okay, it's now time to make sure that you're giving from your saucer and not from your cup. So it's an overflow. We want to build that saucer. We want to fill that saucer up and then have it overflow so that you can give.
Definitely. And when one of the first things you mentioned about the Dutch test is assessing HPA function and adrenal health. And I find that so fascinating. And really, that was a big light bulb moment for me too, because not only in perimenopause, if you look at HPA axis function, you're looking at, a woman after 40, 45, 50 years of life. So there's cumulative stress, but it's so relevant for reproductive hormones. And I think a lot of women don't get that connection where once the ovaries start to go into senescence and menopause, where do our reproductive hormones come from? They come from the adrenal glands. We make DHEA and that gets converted to testosterone and androgens and also eventually into estrogen. So when you make that connection for women that like your estrogen postmenopausally mostly comes from your adrenal glands production of precursors, it's like, okay, well, this is why perimenopause is such an awesome time to make sure that adrenal functions optimized, really to prepare you for the time where you're much more dependent upon
Absolutely.
that. So I just feel like you totally nailed it bringing that up.
Absolutely. I love the way that you pulled all of that together because that's exactly what the conversations that I have. I'm helping you to understand. And it's like, connect those dots. Let's make sure we see the whole picture of you.
Well, so that was going to be my next question, because I think Dutch testing, we get this question a lot. And Dutch testing in perimenopause can be tricky because, you know, progesterone in perimenopause, we see this kind of slow, gradual decline, like cycle over cycle, but estrogen can kind of be all over the place, almost like puberty again. So we get a lot of questions from providers about, like, is there value of doing a Dutch test in perimenopause? So you mentioned like HPA axis and adrenal function, but can you tell me what else, like, what are the key things you look at on a Dutch test, Dutch Plus, for example, for a patient in perimenopause? Is there anything else that stands out that you're looking for?
Absolutely. I also look at the androgen side of that Dutch test because you know what is happening, the way that I see the physiology that makes sense to me, going back to those adrenals, when your ovaries are starting to decrease the production of those hormones, your adrenals are trying to kick in and they're trying to do their job. And this is where I can see, hey, are they really doing what they're supposed to be doing? And so if I start seeing that you're pushing your androgens more towards these androgenic hormones, then I can help explain why you have to look in the mirror and do the little chin check before you walk out the house. And why is it that hair is growing here and stopped growing here? And why am I thinning here? And what's going on? And so it gives me a bigger, broader picture and more in depth when I do the Dutch test and Dutch Plus, because it shows me what your physiology likes to do anyway. So when I start intervening, I can make sure that I have that in mind so that I can say, okay, maybe we need to make an adjustment here. Maybe your dosage should be this. This is where that customization comes in. That's where that personalization comes in. And so that's why I like doing the Dutch, because it gives me insight into your physiology. Do you like to make more E3 versus E2, E1? Do you have the ability to have that methylation activity so that when we put these things on board, your body has what it needs? I say the conveyor belt won't get overburdened. Okay.
Yep.
We know it's
I Love
key.
Lucy video.
Yes, I was like, no, I love Lucy. I say it all the time. I say, y'all remember when Lucy and Ethel had the conveyor belt and then all of a sudden it sped up and they had to start stuffing things everywhere?
That's
I said,
right.
the same thing happens to your body. If you're going at a certain speed and I start putting more on that conveyor belt, your body's going to say, where do I put all this? What happens? And it shows up as side effects.
So you are really giving us the perfect transition to talk about hormone replacement therapy, because I can hear you describing how that perimenopausal Dutch test, which can also be done in menopause before you institute HRT,
Yes.
is a check to say, like, how will your body respond when I put more hormones into the system? So, you know, that's when you're talking about that conveyor belt. Like, is your body going to process it well? And androgens, estrogens, et cetera. So let's shift a little bit and talk about menopause. Now, how do you know when it's time for a patient? And I know this is a joint decision. How do you know when it's time for a patient to start on menopausal hormone replacement therapy?
Oh, I always say the sooner the better, because we know the benefits. We know the long-term benefits, physiological benefits, such as benefits from osteopenia and osteoporosis, benefits on our cardiovascular system, colorectal system, even breast health, brain health, and our immune system, anti-inflammatory properties. So when someone comes to me and they're within that first 5 years of actually stopping that cycle for a full year, because we know that definition of menopause is 12 consecutive months, no cycle. And that's the big thing that I always tell my patients. It's not the hot flashes, night sweats, vaginal dryness. It's not just those three things. It is a complete cessation of your cycle 1 year. And there are other definitions. We know surgical menopause and things like that. But if you still have your uterus, still have your ovaries, not on any form of contraception or any type of hormone, 12 consecutive months, you come talk to me, as the sooner the better, then we can start helping to make sure that we're supporting the physiology so that you're getting the long-term benefits.
Tell me, what are the biggest myths about women getting started on menopause? I'm sorry, on hormone replacement therapy.
Replacement therapy?
Yeah.
Okay. big elephant in the room. It's going to cause cancer. Let's just talk about that. Let's just get it out the way. Is that, oh my gosh, the WHI study has had this lingering narrative of it causes cancer. It causes cancer. And I feel that that's because I feel like I have a special place with the WHI study because it came out July of 2002 when I was an intern, an OBGYN intern. And I remember my program director coming into morning report, waving this paper like, oh my gosh, this was FedEx to my home. Mm-hmm. And so think about this. This is 20 plus years. So the doctors that are seeing you now, we were impacted by this hysterical, oh my gosh, this is not what we thought it was. Hormones are bad, hormones are bad, hormones are bad. And we did not get the retraining and the understanding, hey, those were synthetic. Hey, the average age of this woman that we looked at was 63 years and older.
Unbelievable.
Had a known cardiovascular problem or situation before. And so there were so many little intricate details to that study that we did not have enough PR. I always say doctors don't have a good PR department, right? And so we weren't able to really translate it to how it would relate to the person sitting in front of you. We now know, after a lot of reading of the data and reanalyzing it, that when you look at bioidentical hormones, okay, we're not looking at the synthetic, we're not looking at the conjugated equine estrogen or the progestins, okay, and that's a whole nother topic about how we classify these things. If we look at bioidentical hormones, those hormones that look just like what your body made, there is no increased risk of having cancer above you being just a woman. Mm-hmm. Yeah. And so that's the big myth I talk about a lot.
I love that. And I completely agree with you. I mean, even the risk of progestins was very low. The increased risk. It was like an additional one case in 1,000 applications, which that is less risk than being obese. It's less risk than like a glass of wine a day. So I think there's so many things that even with the WHI data, the media spun it to make it sound so bad when really, how many menopausal women drink a glass of wine a day? A lot, right? So it's like you're willing to accept that risk, but you get so much benefit from the hormones. So I love that you nailed that because I completely agree. And do you find that amongst colleagues, because you're a traditionally trained OBGYN, has the awareness and sentiment changed? Or because I'm the same as you, I was a first year medical student when WHI came out. So similarly, it really impacted what I was trained in. Mm-hmm. And I feel like in functional medicine, there's a lot more discussion around kind of a more modern analysis. But has that translated? Like we do see things come out of NAMS, but has the sentiment changed?
Not yet. Okay. It is such a slow change. I had a patient just here this week that she said, oh my gosh, my doctor literally chewed me out for being on this stuff and was like, well, if you're going to do this, you're on your own.
Wow. I'm glad to talk about this because I think if you're listening and you have a doctor who, gives you the impression that hormones are dangerous, it probably comes from this antiquated training, which is like lowest dose of hormone, shortest time possible.
Exactly.
That's what I was trained in, right?
Exactly.
And so if they're not aware that the research has changed, you might need to work with someone who is more current with literature and know also that like you could even get the literature yourself to share with your doctor if you wanted to work with them. But I think it's something that's important to know because there isn't really controversy on the data. From my point of view, even when you read the North American Menopause Society's modern statements,
right,
they support the use of hormone therapy for most women.
Exactly. They said the gold standard is really hormone therapy for their symptoms. Mm-hmm. And so that was the other thing I think I said to the patient. I was like, even NAM says this is the gold standard, right? This is what should be available and offered.
Definitely. So let's talk about Dutch in menopause and with hormone replacement therapy. How do you use the Dutch test when you're prescribing HRT?
So what I do is I will start somebody on a regimen, depending on what their symptoms are, and being able to help them to alleviate those symptoms. And then I will say, hey, after you've been on this for probably about 8 weeks, maybe 2 months or 3 months, let's revisit and let's see how you're processing the dosage that you're on. Because what we want to make sure of is that your detoxification pathways are open, your nutritional organic acids are at the levels that are necessary to be able to support the reactions that are necessary for these things to happen in your body. And so we just want to do a check. And, or I may do it a little earlier if somebody calls me and says, oh, I'm feeling this symptom, like this is starting to happen, and say, oh, we need to check and see what do we need to adjust. And so that's why I like the Dutch, because it gives me that insight of not only what's in the bloodstream, that's what serum testing does. It tells me what's floating around and available, but Dutch tells me what was sucked into the cell, utilized, and then I get answers on the other side.
That's great. And I know that you are probably looking at all those checks as well on like all of the hormones and
All of them.
metabolites, which, it can be so helpful. What about from a dosing perspective? Do you find the Dutch test helpful to help women get the dose right? Or do you trust mostly serum for that or nothing?
Um, I'm probably one of those old heads
Yeah.
where
Okay.
I've had my protocols for a while.
Yeah.
So because of the symptomology that I hear, I usually go and I look at the Dutch and I'll say, let's start you here and
Mm-hmm.
let's go from there. And so I do have kind of my standard doses where I'm comfortable, and I will tell someone, okay, I'm starting you low and we're going to inch up because of the situation. Or I do have some people, I'll say, look, I am actually starting you at a higher dose than I would normally because we really need to get these symptoms under control. And so we will adjust for any side effects you have, because I really want you to get sleep, or I really want you to stop having hot flashes, or I really want you to be able to see the benefit of this very quickly. And
Yeah.
so I'll ask them, I'll say, this, we can either start at this dose. This is what this means. It means that we're going to go up slower. We're going to titrate up slowly, or we're going to start here and we're going to have to back up.
Now, on top of bioidentical hormone replacement therapy for women in menopause, are there other strategies that you like regularly recommend that some of our listeners might find helpful? Lifestyle, herbs, nutrition.
I do. I love supplementation, and I love targeted supplementation. Okay. So I really like being able to support the adrenals depending on what the Dutch test does. I love being able to tell ladies how, hey, do you see how your cortisol and cortisone are so not in balance? Like, I'll show them and I'll say, cortisone is like going to the gas station and filling up on 87 octane gas overnight when you should have been filling up on 93, which is your cortisol, which would help you get through your day. Both of them, you should start up high and then you should start nicely titrating down over the day so you can turn your brain off, land the plane. Well, if you're starting up here with cortisone and your cortisol's down here, I like to be able to help you convert that cortisone to cortisol because it'll help you get through your day better. It also helps me, it gives me a little cheat sheet also to say, what's going on with that thyroid? Because the thyroid can affect this, right? So that's why I look at your thyroid as well, because I want to make sure that you're converting that T4 to T3 very efficiently. And if I see some markers or indicators, maybe there's some inflammation going on that we need to address. And where does inflammation come from? It's that gut. So then I start looking at the gut health and making sure that we're taking care of that final phase of detoxification and making sure that everything can pass through the piping system, so to speak. So I love to do some type of supplementation for the adrenals. I personally like licorice root, and I know I'm one of those weird people that actually likes licorice. So my kids are just like, "Ma, you like that black jelly bean? Like, really?" I'm like, yeah, I kind of like it. But I tell you, when I take my licorice root in the morning, I get to the end of the day, and it's not like it took me up high, and I was like, "Yes, I have all this energy," but I get to the end of the day, and I'm like, "Huh." I don't feel drained. I didn't want that Snickers at 3 o'clock in the afternoon. I didn't look for the salty potato chips or the sugary drink. And I was able to get through my day and go, okay, that was nice. I had enough. I was able to do what I needed to do, and I'm not crawling into bed, and I'm not shutting out the world going, oh my gosh, that
Mm.
was so hard today, you know?
Yeah, licorice is awesome. I mean, I don't know if you've ever had licorice solid extract. It looks like a sludge in a jar, and it's basically licorice concentrate that they spin down and concentrate to like the texture of honey. But that's one really nice way to take it. It's called a solid extract, and you could like mix it into hot water to make like a tea. If you
Thank
like
you.
the way it tastes, it's kind of sweet too. So if you like the taste of licorice, that's a nice option for you. I
Thank
think just
you.
for listeners, licorice can raise blood pressure. So
It
if someone
can.
has high blood pressure,
Yes, you
it's
have
not a
to
good
figure
option, but if you don't, it's like an awesome, awesome adrenal herb.
it
So,
can.
but
Yeah.
I'm glad you mentioned that, and it has one of the most impactful benefits to cortisol
It does.
as
It
well.
does.
Mhm. Yeah,
And I love doing things that will just support the adrenals, like certain mushrooms, and making sure that I have, even ashwagandha, if somebody can tolerate that, or
love that.
eleuthera root. Those are some of my go-tos where I'll do something that has a blend of holy basil in it as well. Oh my gosh. So I'm sorry, side note story. And I hope I can be, it's okay with me to be this transparent.
Of
But
course.
at one point I was burning my candle on two ends, burning on both ends, right? I was doing a lot, and I felt it. I was just spent. It was, oh my
Mm.
gosh. And I had a nutritionist that I was working with at the time, and she actually said to me, she said, you know what? Why don't you try some holy basil? And I was like, really? I not actually really done a lot of deep dive into that. And she's like, okay, this is how you're going to do it. And she had me do a little titration where I did a nice hearty dose and then I titrated down. I remember the first couple of days, I was just like, where has this been all my life? And can I take this forever? Like, really? I felt like the shades had actually opened all the way up, and I
Wow.
felt like, like a nice little hug around my adrenals. Like they were like, we're good today. We're really okay. Do what you have to do. But I know, you just can't stay on holy basil, indefinitely. And I've had patients that have had heavier cycles when they start taking holy basil as well. So we have to make sure that we understand how that can impact your estrogen receptor sensitivity as well.
So, just in wrapping, tell me like what's the biggest mistake women make in perimenopause and menopause, and what advice would you give them to do it right?
The biggest mistake I think women make is that they minimize their symptoms, and they allow themselves to be skewed in a different direction. What do I mean? Or pointed in a different direction, or they are, let's just say it, they're basically medically gaslit. They go in and they say, these are my symptoms. This is what I'm doing. One, is this something to do with menopause? They're told no because you're too young. So everybody thinks it's a number, you have to be a certain age. So I tell them no. If you are experiencing some changes in your body, be your advocate. Be that advocate for yourself. And I tell patients all the time, I say, you can fire your doctor, right? Like if they are not if you all are not having the relationship that is beneficial for you, then find somebody else. Okay. And so I think one of the things is that women can recoil and suffer in silence. I'm glad to know that the conversations are getting louder so that more people are joining this conversation, and that it is actually bringing light to this. And so I say a lot. I There was a paper that just was published in July, middle July, by Dr. I think it was Dr. Wright, Dr. Vonda Wright and her team, called the musculoskeletal syndrome of menopause. And it detailed how a lot of us wake up with these aches and pains. We go to our physician, we go to our orthopedist, or we go to our internal medicine doctor. We get an image done, and there's nothing on the image. But knowing how estrogen affects our joints, how it can help decrease inflammation, this is part of what is happening. I think a lot of times, what are these symptoms of, oh, you're just getting old? Oh, welcome to the over 40 club. Oh my gosh. Yes, girl. I know about that. It just is what it is. That is not going to be the same sentiment. if we keep having this conversation and making it louder and helping people to understand your hormones play a significant role in your body's ability to function. And when they are not at the level that they used to be or should be, they show up as real symptoms.
Fabulous. And let's hope It Is What It Is becomes a vision of women, living their optimal health, their optimal life well into their
Yes.
60s and 70s and beyond.
Absolutely.
I can tell you're going to take us there. So thank you so much for joining me today. It's been such a pleasure to get to talk with you, and really thank you from Dutch and from myself as a woman, as another clinician, for taking such good care of women. The more providers out there and the more providers you can reach through your platform and through our platform to help women in this way, like, we really are going to make a big difference. So thanks for the big impact that you make.
Thank you.
If you're wanting to learn and really expand your expertise in hormones, you're not going to want to miss our podcast. So make sure you tune in each and every week for our new content.